Good evening and welcome back to the second session of PGDGM program. We are discussing the respiratory system with respect to the elderly, and in the second session we will be taking the common respiratory problems in the elderly. Now we will be discussing the approach to the various common problems that are encountered in the elderly. What are the clinical presentations, what is their investigations that must be done, and the management of these problems. So I would request Dr. Anuradha to tell us what are the common problems that occur in this elderly age group.
Very good evening to all of you. And if we see across all the respiratory system disorders that exist or that can manifest in elderly patients, there are 3 or 4 of them which are very common, and I shall be briefly touching upon the clinical features, the presentation, how do you investigate these and how do you manage them very briefly. And the 3 most important things that I shall be touching very briefly upon is, the first are infections. Infections are very common in elderly patients. They could be a pneumonia, they could be bronchitis, they could be tuberculosis. So infections are one common problem. The other very common problem that we see in these patients is chronic obstructive pulmonary disease or chronic obstructive airway disease. And the third most common and in fact most devastating problem that we see in these patients are lung malignancies, and I shall be very briefly touching upon each of these problems.
Now why are the elderly more prone to infections?
There are many physiological changes that occur with increasing age, and some of these physiological factors or physiological changes that occur actually predispose or put the elderly at a risk for developing infections. So that is why we find that elderly patients are at more risk to developing infections. They develop more severe infections, and their presentation is very different, and their response to treatment is also not as efficient as it should be as it is in a younger adult. So there are these certain physiological changes that occur with increasing age which are likely to put these patients at much risk, and these physiological changes that occur in the respiratory system are that there is an alteration in the mechanical barrier to infection. So that is the first thing. So there is always microaspiration which is occurring, and there are increased tracheal, because these microaspirations, the tracheobronchial tree keeps on getting colonized again and again, and if this colonization then becomes invasive, then these patients tend to develop respiratory infections. There are problems with weakened cough, so patients are not able to expectorate out these aspirations. There are problems with immunological problems, that there is low IgA, low lysozyme in the nasal mucosal secretions which act as a barrier to colonization. There is decreased mucociliary action which is again predisposing to infections. There is a collapse of the lower airways which occurs in these patients. There is alveolar macrophage dysfunction which occurs in elderly patients, so they are not able to clear out the lower respiratory tract infections. And there is much more residual volume in these patients. So more residual volume means more contact time between the microorganisms and the lung surface. So all this puts the elderly patients at much greater risk for infections, and that is why if you see overall, if you see all the respiratory problems, the 2 most common disease states that impact the lung health are a pneumonia and chronic bronchitis. And if you see, pneumonia itself was found to be the 3rd most common reason behind heart disease and fractures for hospitalization. That means the 3rd most common cause of hospitalization in an elderly patient is a pneumonia. So that is how important it is for us to know about the presentations and management of a pneumonia. And if you take combined with pneumonia and chronic bronchitis put together, they are second only to heart disease as an initial diagnosis of a geriatric patient. And individually in the elderly age group, pneumonia is the 5th most important cause of death. So that actually tells you what the impact of pneumonia and chronic bronchitis separately and individually have on the health of patients.
So that means it is the inherent aging process itself which predisposes an elderly to the infections, and that especially pneumonia.
Yes. So there are certain, like we discussed, there are certain physiological changes which are inherently predisposing. Aggravated by that, there are certain other factors which we will be discussing, and they put the patient at much more risk of developing a pneumonia, and pneumonia itself can give rise to so much of mortality in these patients that it is very important to remember. So when we are talking about pneumonia, it is the 3rd most common site of infection in an elderly. It has a mortality rate of 30 to 50% in these patients, and there are many risk factors for this. Most pneumonias in elderlies are due to aspiration, whether it is obvious aspiration or it is microaspiration which is occurring. The pathogens that cause the pneumonia most commonly would be pneumococcus or streptococcus pneumoniae. H. influenzae and other gram-negative bacteria are also important in elderly patients, especially those who are institutionalized, those patients who are in care facilities, other institutional care facilities, other old age homes. These patients are more likely to develop infections with gram-negative bacteria, and most of these are transmitted by droplet infection and so spread from one to other. So that is why patients who are elderly patients who are living in old age homes with much close contact with others, they are likely to spread the infection from one person to another. And like we said, in addition to the inherent physiological status that occurs in these patients, there are so many aggravating factors, that is including alcoholism. Any patient which develops altered mental status, suppose a patient develops a stroke, he is at a risk for developing a pneumonia because he is likely to aspirate more. Other comorbid conditions, for example, chronic obstructive airway disease, heavy sedation, patients who are on sedatives, long-term sedatives, patients who are paralytic because of neurological involvement. So these patients again are unlikely to clear their secretions and are at more risk for developing a pneumonia. Malnutrition is a big problem that contributes to pneumonia. So an elderly, alcoholic, malnourished patient is at very great risk for developing a pneumonia. Many medications that decrease the gastric pH, especially patients who are on long-term anti-ulcer medications, it has been said that it may predispose to pneumonia in these patients. Patients who are on nasogastric tubes for feeding for some other reason, again it may sometimes cause a pneumonia. Poor compliance with infection control. This is especially true, like I said, again in nursing homes or in care facilities for elderly, where from one elderly patient to the other elderly subject, if standard operative procedures or standard precautions are not followed, a pneumonia may develop. And if the patient is kept supine for a long period of time, these patients may develop a pneumonia.
So what are the common presentations like? Yes.
When we talk about presentations of pneumonia in a young adult, it would be very classical. Patient will have fever, will have cough, will have expectoration, will have chest pain, and your diagnosis is very clear-cut when you examine a young adult who complains of these symptoms, and your diagnosis becomes almost certain that he has a pneumonia. In an elderly patient, this is not true. There are very minor, very subtle manifestations of pneumonia, and we can actually never even think that pneumonia could be presenting as this. And so one needs to be aware of all these presentations of elderly patients presenting with pneumonia. And like I said, the presentation can range from very subtle signs that for 2-3 days a patient is just lethargic or anorexic or is having excessive falls. A very common complaint is delirium. So elderly patients who present suddenly with an alteration of consciousness or alteration in mental status, even without any features pointing to respiratory involvement, one must always think of a pneumonia as a possibility. Never forget that any patient who has acute onset or subacute onset of worsening of mental status, the differential diagnosis in an elderly patient must always include a pneumonia. If pneumonia is persistent and if it leads to more problems, patients can present with septic shock. Patients can also present with very acutely with acute respiratory distress, adult respiratory distress syndrome. The next slide, if I have a slide. These components, pleuritic chest pain, dyspnea, productive cough, fever, chills or rigors, these are not consistently present in older adults, and this fact needs to be emphasized again and again. So these classical signs of a pneumonia may be completely absent in elderly patients who present with a pneumonia. When we examine these patients, they will be tachypneic, having an increased respiratory rate. They may be having hypotension. Another, like they don't have florid physical symptoms, they may not have florid physical signs. Physical signs of pneumonia in a young adult would include bronchial breathing, crepitations, and patient having increased body temperature. In these patients, there may be very minimal chest signs. You may not get anything on chest evaluation, or you may get occasional crackles or inspiratory creps which may be there, or the chest examination may actually be entirely normal. So you may actually think, or there may be such basal crepitations that you may actually think the patient is having heart failure. So you need to be very careful when you assess these patients. And like I have said earlier again and again, up to 20% of patients are actually afebrile. They will never have fever.
So this shows that actually pneumonia diagnosis itself is a very tricky thing, and
Yes.
I think it is more important as family physicians for us to counsel the caregivers and the
Yes.
family members, because such patients would never be brought or would never come to the physician even when they are very sick. And so we should not just, I think the single most important sign that you have said is the delirium. And that is one thing which can be picked up very nicely by the family members, because they are staying close to the elderly, and it is in fact I think more difficult for a physician to pick up a sign in the elderly rather than in a family member, because sudden change in the awareness, behavioral level and the consciousness level,
Yes.
I think is more important, and they should be alert to this kind of a thing. So I think rather than just we also always say that during history of elderly patient, we have to collaborate the history with the family members, and we have to cross check. So in fact especially inbuilt in our program, we have got that they have to visit the families, so they should build up this skill of trying to detect and trying to counsel the family members as to these are the signs or these are the symptoms. If observed by the family members, they should be picked up, and they should be they should ask the family physician to investigate further.
Also, very simple things that they must always remember: patients who are moribund, say elderly patients who are bedridden, never feed the elderly in a lying down position. Never do that. If a patient is not able to sit up, please support the patient, semi-recline the patient to 45-degree angle, and only then feed. If you are going to put fluids in the mouth or put food in the mouth when the patient is lying down, it is much more going to increase the risk of aspiration and pneumonia. These are strict no-nos. Should never do these things. So these are very simple instructions that you can give to the caregiver, you can give to the nursing home people, or wherever the elderly patient is there, to the patients who are to the persons who are actually involved in caregiving, to follow very simple techniques that are likely to reduce the risk of aspiration and reduce the incidence of pneumonia in these patients.
We have received a fax from Hyderabad. I think we have only Hyderabad students who are viewing our program, it seems, and the point is that I do not know whether we should have the teleconferencing open for the other centers unless they tell us that they are sitting there and they are listening to us and they have any questions or not. Anyway, I thank you for your fax, and I would just read out the fax. I think the same thing has been faxed twice, so one copy I have given to Dr. Anuradha. The first question is that they have asked any further descriptions of the quantity and quality of the expectorant. So would you like to comment anything on this question?
Quantity and quality. Quantity, the patient can, you have to gauge the quantity by how much it actually is expectorating. The subject is actually expectorating, whether it is spoonfuls or whether it is cupfuls. So that's how you can assess the quantity. It's very difficult to actually get in terms of ounces or mLs, because it's a difficult thing to do. No, even if you have an expectoration or I have an expectoration, we know if it is mild or if it's moderate. We generally don't actually measure it, but you can get a rough estimate.
I think her the meaning is probably that, you know, what can you say based on the amount.
Oh, okay.
That is the interpretation of the amount, I think, and the quality, or the color and that.
Interpretation of quantity, well, patients who have chronic respiratory disorders like obstructive airway disease are likely to produce large amounts of sputum. Patients who have suppurative lung diseases like bronchiectasis, like lung abscess, are likely to produce large quantities of sputums.
It will be positional also.
Yes, it could be positional also. Patients with interstitial lung disease are less likely to produce, likely to produce less amount of sputum. So excessive sputum production will tell you about these things. Patients with chronic bronchitis produce large amounts of sputum.
Even they will produce colored sputum because they will be infected.
Yes, if they have a superadded respiratory infection, the sputum may actually be mucopurulent or purulent, that is yellowish. In an abscess, it may actually be greenish sometimes, yellowish, thick, greenish sputum. Like we have talked about hemoptysis, and that again, that's all we can say about expectoration right now.
Then there's another question that has been asked about standardization of PFT.
So I am not really sure as to what they mean by standardization of PFT, but I am sure that whenever you are installing a PFT pulmonary function test, and I presume you are talking about a spirometry, you must have the normal for your population against which you are talking about, against which you are going to talk about your patient. So 80% of normal or 70% of normal, so you must have a normal for your subject population in that country, and I think we do have values, and you need to do it on normal people in your area and then assess your patients against. And I think that's what is meant by standardization of PFT.
Then we have this significant period of absence from smoking to equalize with non-smokers.
Right. it is important, like I said earlier also, that but there is no time frame that beyond 2 years it is going to be less or beyond 3 years it's going to be more. But as the duration of non-smoking increases, that is as the duration of abstinence increases, if a patient has been abstaining for 15 years, the risk of that smoking is actually negligible. You can take them equivalent to a non-smoker. So this beyond a decade, generally they say that the effect of that smoking actually disappears. So that I think will solve the problem.
I think there are many other factors also which are related to that. That is, could be passive smoking.
Yes.
And it could be he's living in a polluted area,
Oh,
or
yes,
not
yes.
polluted area. So
I didn't touch on passive
Yeah.
smoking at all, because it's a very big problem. Because somebody who is exposed to cigarette smoking by another person in the home is at much more risk. So that is passive smoking for so many years.
Cities, the smoking has probably gone down, but the pollution levels in the environment otherwise have gone up.
Oh,
So I
yes,
think they have
absolutely.
become a bigger problem.
Similar, I think the same thing applies to the next question that they have asked is pneumoconiosis. After how many years away from that environment you can take that to be insignificant? I think it's almost similar to smoking. I mean, can ramipril also cause cough? Yes. All ACE inhibitors can cause cough. Some cause more, some cause less. But it is a class effect. It is not an individual drug effect. All ACE inhibitors, irrespective of ramipril, enalapril, whatever, can cause cough. Some cause more, some cause less. Definitely, but all of them can cause cough. The quantity of the sputum that helps differentiate between respiratory from quantity or quality? Quantity, no?
Quality hoga, just quality.
Quantity will not help you differentiate.
Quality.
Quality, yes. If you are having mucoid, mucopurulent sputum, purulent sputum is more likely to be respiratory. If a patient is having light, whitish, more like saliva, white, sometimes even light pink, it is more likely to suggest acute left ventricular failure, but then the presentation will be entirely different. I mean, LVF will present with sudden onset dyspnea, frothy sputum. That's likely to be more cardiac rather than respiratory. So I think that serves the purpose. And I think the last one is directed to you.
Yeah, video clips of respiratory and cardiac sounds if possible. I think this is a very good suggestion, and we would try taking it up and try to get them recorded. And we of course take the help of our academic counselors, and if it is possible, we would like to, because we would like to have these tapes. I think for the adults they are available, but for geriatric patients they are not yet available. But in some way, if we can, get them either from outside from the outside country, or if we can get them prepared in house, let us.
I think in due course we should be able to develop our own.
We will be able to develop, and I think that we will.
And I am glad to see that there are 9 candidates who are
Yeah.
sitting in Hyderabad Center and watching our program. So thank you so much.
Thank you. I think now coming back to pneumonia, I would like to you to tell us about the examination, the physical examination, the investigations which need to be taken.
We've just spoken about the physical examination. I think we'll quickly go on to the investigations that can be done and that need to be done in assessing a patient with a suspected pneumonia. Of course, the most important remains the chest X-ray, and it's important to remember if the patient is very dehydrated or if you're doing the chest X-ray very early, your infiltrates may actually not be seen, so you may actually need to repeat a chest X-ray maybe after 24 to 48 hours or after achieving adequate hydration. Sputum examination is actually not a mandate for diagnosing a pneumonia. In fact, some of the societies do not even recommend a sputum examination. If you do a complete blood count, you may have evidence of a left shift and leukocytosis, which again will point to an acute bacterial infection. It's very important to do blood urea nitrogen, creatinine, electrolytes, glucose in these patients, because these are alterations in these parameters actually increase the mortality and morbidity in these patients. Very important to assess oxygenation or arterial blood gas. If you are able to do an ABG, very good. Otherwise, you must monitor these patients by pulse oximeter to see what is the oxygen desaturation, because patients who are going to show evidence of cyanosis will have much more morbidity, much more mortality. I'm going to show you a few X-rays. This is what a classical lobar pneumonia looks. Well, this you may get in an elderly patient, you may not get such a classical homogeneous opacity. What you are more likely to get is something like this, which is a lower zone opacification, which is not complete, which is there probably on this side also, so bilaterally it could be there. You can get this kind of a more dispersed bilateral picture, which is very common in elderly as presentation as a bilateral bronchopneumonia, more than the classical lobar pneumonia that you saw in the first X-ray. And if your pneumonia presents with one of the complications, your patient can present with a lung abscess like this. If you can see here, there is a very rounded opacity and there is this very well marked air fluid level, which tells that patient has actually now developed a lung abscess in this.
You can come to the management, I think, of pneumonia.
Yes.
Yeah.
When we talk about management, there are two aspects. There is a supportive care that is very important for these patients, and of course then there is the definitive management. Chest percussion, chest rehabilitation, physiotherapy, extremely important for these patients to be able to expectorate out. If they are having evidence of wheeze, you may need to give a bronchodilator. If there is evidence of significant oxygen desaturation, you may need to give oxygen or mechanical ventilation, and you need to give good hydration and nutrition to the patients. Supportive and specific treatment of course remains antibiotics. The choice of the antibiotic very importantly depends upon whether it is a community acquired pneumonia or a hospital acquired pneumonia. A hospital acquired pneumonia is a pneumonia that occurs in a hospitalized patient. Okay, so the organisms are more different, the infection is more severe and serious, and the response to standard antibiotics is likely to be less. So you have to base your choice of treatment depending upon whether it's a community acquired pneumonia or it is a hospital acquired pneumonia. A brief word about pneumonia prevention. Like I said, there are certain simple things like sitting at 45 degrees and eating, not putting foods while lying down. But there is also a very important component of pneumococcal vaccination that is very important. All elderly patients who have chronic illnesses and are more than 65 years old should be receiving a dose of pneumococcal vaccine. It is very, very important and it should be remembered by everybody. So all COPD patients who are more than 65 years old should receive a single dose of a pneumococcal vaccine.
Chronic illness you mean related to the respiratory?
No, actually this means all illnesses. Even a diabetic actually should be getting a pneumococcal vaccine, but since we are talking in terms of a respiratory illness, here I stress COPD, but all elderly patients more than 65 who have chronic disorders need to be on a need to receive a pneumococcal vaccination.
And like even those who are bedridden, who are in coma and all, it's very much important because
yes,
aspiration is very much increased in such patients.
Yes, yes. So your
neurological patients.
Yes, yes. So
chronic,
yes, yes. So please remember, it should be a part of your standard care you are offering to these patients. And there are many methods by which you can actually reduce aspirations. I cannot go into the details, but encourage mobility, prevent or decrease the use of sedatives, check the nasogastric fluid, feed slowly, feed at a recumbent position, and these are very simple things. There is also influenza, which is very common in these patients. Influenza attacks both the very young and the very old. Influenza vaccines are available, but unlike pneumococcal vaccine, which provides protection for 5 years, influenza vaccine needs to be given annually. Every year there is a different strain of influenza viruses which are available as a vaccine. Patients with COPDs, interstitial lung disease, you need to vaccinate them annually for influenza.
We have another facts from Hyderabad.
Okay. They are very active.
They are very active. It's very nice because this is the purpose of the teleconferencing, not just providing information. So they have asked risk stratification of smoking in respiratory diseases. Please explain in detail. I think you may have mentioned risk stratification of smoking in respiratory diseases.
No, there is nothing like risk stratification with respect to smoking. Risk stratification is more used in terms of coronary artery disease. Risk stratification meaning, from what I can gather from the question is that whether it is different for different kinds of cigarettes or BDs, but yes, cigarette smoke is much worse than smoking BDs, that is definitely there. Somebody who smokes less is definitely at less risk compared to somebody who smokes more. Okay, heavy smokers are naturally at more risk. Duration of smoking again is at risk. So what type of cigarette or what type of BD, what type of smoke you are inhaling, whether it is cigarette or whether it is BD, that increases the risk. The number of course directly influences the risk. The duration, if you smoke for 5 years, 2 years or whatever, and like I said, whether there have been abstinence from smoking or not. I think that's
probably they also mean that whether there is some standard stratification that is available or not. Whether some organization or some association has done
I am not really aware of there is any actual standard method for which you can risk and assess, and you can you can
categorize
them into grade 1. Yeah, I am not aware. Maybe I'll get back to you later. But this is what we have. This is how you assess risk of smoking. This is how you do it.
Yeah. In case there is such a information,
Please,
then
I will give it
send
to you
in
so
the
that we
next
can pass it
teleconference.
on, so that in the next teleconference you get the answer for this.
Yeah.
Definitely. So we'll take
So
the...
we can take the next disease, that is chronic obstructive pulmonary disease.
It's a very common, very important problem that we will be discussing. Very important definition: it is a preventable and treatable disease with some significant extrapulmonary effects that contribute to the severity in individual patients. The pulmonary component of COPD is characterized by airflow limitation that is not fully reversible, and this is how it's differentiated from asthma. In asthma, the airflow obstruction that occurs is reversible to very large extent. Here it is irreversible and progressive, so that's why it gives rise to normally problems, and then airflow limitation is usually progressive, and that is why it has a more progressive and chronic course. There is a lot of problem with COPD. It is a leading cause of mortality worldwide, and in the US and Canada, COPD mortality has actually been increasing, and this is something which is very alarming if you see. Now these are some very important graphs that you must see. If you see what is happening to the death rates for major illnesses. Coronary heart disease, death rates are going down. Stroke, mortality is going down. Other cardiovascular disease, mortality is going down. All causes, mortality is going down, but the only mortality rate which is actually rising over a period of 30 years is COPD. So this is not a good thing, which means to show that COPD mortality is actually rising. Another thing is that since 1970, if you see, all cause mortality from heart disease, from cancers, from strokes, from accidents has actually gone down. The only mortality figure which has been steadily rising all across is chronic obstructive airway disease, and this is very alarming, and this is causing a major problem. And this is true for both men and women. If you see for men, again there is an overall increase in mortality from 1980 to 2000. So in the last 20 years, despite the fact that we know so much about COPD, mortality is increasing for men as well as for women. So the mortality because of COPD is causing a lot of problem, and we need to remember this, and this is very alarming, and it is very preventable. If you stop smoking, you can actually prevent the problem. It's a very simple thing to do, but unfortunately it is not happening. There are many risk factors for COPD, and the most, of course, there is a very strong genetic component, and this is important to know because there are so many smokers in the world. Despite the fact there are only some of them who actually have COPD. Why some of them don't develop COPD, we really don't know. So probably there is some genetic component involved. And of course, exposure to particles is a very important thing. Tobacco smoke, all other kinds of smoke, indoor pollution, outdoor pollution, gender, age, nutritional status, comorbidities, many factors, some known, some risk attributed, some risk not yet completely attributed. All of them can cause smoke.
I think exercise should also be lack of exercise
Yes.
should also be a very important
Yes,
risk
yes.
factor, which probably not listed there.
Yes.
But I think because it increases your lung capacity, and
Yes.
it does help to prevent COPD. But since most of us are leading sedentary life, and so are the elderly, and even re-employment and employment till the age of 60 and then 65, and then going in as consultants, so I think their exercise is going down. And second, I think very important nowadays, which has come up, is the indoor air pollution.
Yes.
Not only in the rural areas, but even in the urban
areas,
the
absolutely.
buildings which are totally air conditioned, and they do not have any
No ventilation,
no
absolutely,
ventilation,
and
so
even if it gets ventilated, it is so polluted. So exposure to any kind of pollutant, whether it is cigarette smoke, whether it's occupational exposure. Can I have the graph? Can I have the slide, please? So whether it is cigarette smoke, whether it is occupational exposure, indoor air exposure, combined with very important factors, nutrition. Malnutrition is a very important risk factor. Infections, recurrent infections, very important risk factor. Socioeconomic status, again very important risk factors. And the last and most important is aging population. So put together, these factors are actually increasing the risk for chronic obstructive airway disease. And if you very briefly see the pathogenesis of COPD, once the patient is smoking or whatever the inhaled particle is, with a host of amplifying factors that we talked about, there is persistent lung inflammation, which then gives rise to the COPD. And what happens to the lung is that there are alveolar wall destruction, there are many other pathological changes which ultimately lead to changes in the large airways and also in changes in the small airways, which gives rise to bronchoconstriction, which gives rise to excessive amount of lymphoid tissue proliferation, which gives rise to increased amount of sputum within the airways, and all these things are very important in the pathogenesis. So small airway disease manifesting or large airway disease, parenchymal destruction, both of them together give rise to the most important problem, that is airflow limitation or obstruction, and that is the basic pathogenesis of this. And what is the most dangerous, or what is one of the most important side effects or the long-term effects, is what the changes happen in the pulmonary arteries. And there are so many endothelial hyperplasia, smooth muscle hyperplasia. What this leads to, basically gives rise to, is pulmonary artery hypertension, and this pulmonary artery hypertension then gives rise to right heart failure, which is actually the cause of death in most of these patients with chronic obstructive airway disease. So when do you diagnose a patient of having COPD? So there are certain symptoms which would suggest it, and there would be exposure to certain risk factors which combined would suggest the patient actually has. Then you do a test to confirm it. So patients with cough, sputum and shortness of breath who have a history of exposure to risk factors, you should do a spirometry and then find out. And the three most important differential diagnoses of COPD are asthma and congestive cardiac failure, and you can differentiate it. You can classify it spirometry very briefly. You have to use spirometry because then you can classify it into mild, moderate and severe, and depending upon mild, moderate and severe, your management of these patients comes. And the management is has components of relieving the symptoms, preventing disease progression, improving the health status, reducing mortality, and prevent and treat exacerbations. Remember, COPD patients are at increased risk for MI, angina, osteoporosis, infections, so many other things including lung cancer. So
how do you account for the osteoporosis? I find rest of the problems are okay.
It is known that these patients are at risk for osteoporosis because many times they may be on oral steroids. Okay. So they may develop osteoporosis as a result of chronic oral steroid intake, not inhaled steroids. So you need to be aware of that probability. I will not go into details of the management because it is very long, and COPD itself is a very long and exhaustive session, but you must remember that inhaled bronchodilators, methylxanthines, oxygen, domiciliary oxygen therapy at late stages are very important modalities of treatment in these patients. You must treat exacerbations in these patients, and exacerbation, the most common cause for exacerbation in these patients invariably is a respiratory infection. So if you catch respiratory infection early and treat it early and treat it well, you may reduce the incidence of exacerbations. You may need to ventilate these patients at many point of time because ventilation may actually help in prolonging morbidity, prolonging life in these patients. So at the earliest you must give them domiciliary oxygen therapy, and you must advocate mechanical ventilation if required, and you must do that early. And the most common cause for an acute exacerbation, you must always remember, is infection, which needs to be treated.
I think the hallmark of the thing is that it's more important to prevent rather than to manage COPD, because these COPD, like any other chronic disease, it is very difficult to manage because the damage has already been done. So it's more important to prevent, and so I think the educating the early
and another thing is, even if a patient has COPD, that patient must stop smoking. Whatever severity of COPD that patient has, the first and the most important information that needs to be given to the patient is to stop smoking. Even a single cigarette from that day onwards is very bad, and that needs to be re-emphasized. Irrespective of what stage the patient is, he has to stop smoking because it is only going to worsen it. It cannot ever improve it.
We can, I think, quickly go through the third topic we wanted to discuss, that is lung malignancy.
Very briefly, just few slides on lung malignancy, and this is what is happening to lung malignancies. If you can see that with age, after the age of 55, the lung malignancy increases incidence both in men and women. There are four basic types based on microscopic appearance. The commonest we see, of course, are squamous cell, and we can also see small cell, and very sometimes we do see adenocarcinomas. The causes, again, smoking is a very important risk factor, radiation injury, occupational exposures. These are known risk factors for patients developing lung cancer, but there are many unknown which we are not very clear as to, because sometimes we find that patients are non-smokers and still develop lung cancers. So we are not very sure of exactly all the risk factors. But what we do know is primarily cigarette smoking, and without smoking, lung cancer would be very uncommon. So if all the smokers in the world were to quit smoking, lung cancer incidence will actually come down to very little, because there are very other few causes. Genes, of course, have a role, but we are not very clear as what is happening. So it also depends upon how long the patient has smoked, when the patient has started zinc-leading, and what is the type of smoke that has happened. And like I said, there are genetic influences, there are environmental influences that put the patient. It is important to remember patients can be asymptomatic till the presentation is very advanced. So patient may come to you directly with one of the long-term sequelae or one of the complications. Common when do you suspect? If patient has a cough that has suddenly worsened, even if hemoptysis, even a small amount, you should always rule out an underlying malignancy. Chest pain, shortness of breath, new onset wheezing. A patient who already has wheezing has suddenly worsened, and you must think of that. Repeated bouts of pneumonia, and of course hoarseness. Remember, a change of voice should always alert you to the possibility of an underlying malignancy. Remember, 90% of patients would be symptomatic at the time of presentation. That is, the cancer has been present for a very long time, enough to produce symptoms. And the symptoms could be related to the tumor per se or because of its spread. And just last slide on this is how a lung cancer specimen looks in across two things. And it is very important to remember that when we are managing these patients, that it is difficult at times to treat these patients because they present sometimes so late and with so many extrathoracic manifestations that simple resection is not possible, and we may even need to use only palliative kind of therapy, whether it's radiotherapy or chemotherapy, to these patients depending upon the type of cancers. And I will not go into detail regarding management of cancer because I think that's a detailed topic on its own. So
yeah, we will be taking cancers as a separate topic. Of course, I wanted to announce this, that whatever topics that you would like us to be taking in the next few months, you can always email us, or you can even fax us during the presentations. As per your need, we can put the topics. We have received a fax from Cochin, I think, but a little too late, because the one thing that they have written in the fax is that you're too fast while explaining.
I am actually,
so,
unfortunately,
kindly slow down. Actually, I think we want to cover as much as possible, but of course, I
agree with them completely because pneumonia should have been one topic in itself. Lung COPD should have been probably two topics, two sessions, not one session. So it's impossible to cover 3 sessions, and these are only 3 that I have covered. So there are too many.
I think in case the need is felt that some of the topics
need to be repeated,
explained, then we can have a session exclusively on one of the topics, and we can we would like to invite you to send your questions either through email. I would like to tell you again, my email is ruchikakuba@yahoo.com. You can email us the questions, and we can, in the month of maybe May or August sometime, we can schedule another presentation in respiratory problems, and the questions itself we can take up, or we can just schedule one question answer session in which all the questions pertaining to the various 2-3 teleconferencings that we have been having, if we get a bank of the questions, then we can take up just the difficult topics and the questions which could be related to the teleconferencing or towards your sessions that you have been having in the SDC or the program study center also. There is another one. They have said that there are 8 of them in Cochin. I thank you for your facts. They have also asked that we would like to know more about the pneumococcal vaccination, that is the schedule, dose and the intervals when it should be given.
Very briefly, okay, patients, all adults, it's actually now the component of adult vaccination is very, very important. It's actually sometimes most of us forget about vaccinating adults. A pneumococcal vaccine is to be given for a very specific group of patients. Patients having chronic disorders, patients who are splenectomized, even young adults, splenectomies, patients having HIV disease, early HIV disease, patients having other immunosuppressive illnesses. All these patients need to be vaccinated with pneumococcal vaccine. The pneumococcal vaccine is available as a 0.5 ml unit, 0.5 ml vaccine to be given once every 5 years. The pneumovac that is available has a duration of action or protective efficacy for 5 years. So you need to repeat it every 5 years in case you need to do it. So once if you give it, it is effective for next 5 years. And unlike influenza vaccine, which needs to be given every year, because these strains of influenza that are prevalent in the country, it is decided that which are the common prevalent strains during that year, and vaccine is developed against them. So influenza vaccine annually, but pneumococcal vaccine once every 5 years.
I think it's very important, and especially after seeing today's presentation, they must have realized the importance of pneumonia and so the importance of the vaccine also. So I think we would be now ending our session today. I'd like to thank you, Dr. Anuradha, for
Thank you, Dr. Ruchika, but I agree with some of your viewers that there is very little time to cover so many important topics. But
just one thing more I would like to tell you, that we had shown a short film. I'm sorry I did not announce that at the end of the first session because the time was already over. We had shown a short film which was a kind of information about the various programs of the School of Health Sciences, and also how distance learning can make an impact in the continuing education of medical doctors. This is a small film that we have prepared. The purpose of showing our film was first to orient and make you aware about the various other programs, and we would also like to inform you that this film is available in case some of you would like to have this film for showing it to your state governments, or for if you are going in for a if you're going in for presenting a paper in which IGNO is involved and you would like to tell how IGNO is can spread the message, can do the training of medical graduates, then you can write to me and I can send you a copy of the film. And also if you want to have the state governments for making an SDC, for example, I know that in the state of Uttar Pradesh, the SDC, the state government has still not very much agreed that the SDC should be there in the government hospitals. So you can take this film for me and I would be very happy, because now we are having a good number of students who have already passed out, and so you can influence the state government for having this training program in as many hospitals as possible. So with this I would thank you, and again remind you that the next teleconferencing is on 29th April from 2:30 to 4:15, but kindly confirm the schedule from the website before you come for it. Thank you.